This is Captain Marchese. I'm going to be recording a slideshow on SOAP notes and vitals, finding yet another way to beat this information into everyone's head. Super important, so let's go ahead and get into it. Basically, the purpose here is to make sure that we're adequately documenting everything that happens at our aid station, and that should be done on a DA Form 5181. There's a lot of reasons that documentation is super important. And so coming from a civilian background, that's something that was definitely beat into my head when I was a young EMT and like being trained as a PA, that if something isn't on paper, it didn't happen. And so we were basically taught that like you were subject to any legal repercussions if you didn't put everything that happened on paper. And it's your word against the casualty, the soldier, the patient. They're going to win if you didn't write it down. And so that's one of the many reasons that documentation is super important, but there's so many others because it's also important for the safety of our soldiers that are coming in. This is the way that I can read over your notes and verify that we're taking the best care of people that we can. That's what I think is the most important out of all of it, is like, I want to be able to read these notes and know what your thought process was and what we did for these people, and how we can better take care of them in the future if somebody comes in with the same issue. That's the most important thing to me and why I care so much about what we're doing here. There's also, and that's super important for our soldiers who are 20 years and they're retiring, and if they've had no documentation of years worth of issues that they were seen for, that's not fair to them and we're not really doing them justice. Okay, so that's a few of the many, many reasons that this is super important. So we'll be documenting all of the encounters that come into sick call on a DA Form 5181. So basically this form is designed so that anyone who's coming in with a new issue and we're using ADTMC to treat them, it should be on this form. There's also an SF600. I won't get into the SF600 a whole lot in this presentation. It's basically the same as a 5181, except it doesn't have the front page with all of the boxes. It's just simply a SOAP note. And so SF600s can be used for like rapid ER transports where we're not really looking at ADTMC, or they can be used for quick follow-ups that happen at the aid station where it's not the first time they came for this issue and we're just writing a very quick follow-up and we're going to attach it to the 5181 that they originally came for. So this is just a screenshot of the 5181. You can see all the boxes on the front where you fill out various information, and we're going to get into the details of that later, but I just wanted to show it up front here. And then on the back is where you would write your SOAP note. So let's get into actually how to properly write a good SOAP note. So basically, when we talk about SOAP notes, SOAP stands for Subjective, Objective, Assessment, and Plan. And that follows through everything that we need to do every time somebody comes in with a new issue. So we'll start with subjective. So subjective is, this is the patient story. This is what are they telling me is going on. I personally use OPQRST as an acronym. There's many different versions of OPQRST, and there's even slightly different acronyms like old carts. The way I see this is I don't care what acronym you use to make this happen, but you have to get all the information that we need. So if you get all this information, but you use a completely different acronym, I don't necessarily care at all. And I don't necessarily care about the formatting of this. Some people do it in paragraph form. Some people will actually write out OPQRST, especially when they're first starting out. And I personally don't care either way. Whatever gets information onto the 5181 is perfectly fine for me. So basically, let's get into OPQRST. This is the one I'm going to teach because it's what I use on a regular basis and what I'm most familiar with. So O stands for onset, and that's basically when did this issue start. It's super important to get an actual number for this. I don't want it's been going on forever or a long time or like many years. If they give you an answer like that, you have to kind of bait them into giving you a real answer. It's where it's like, okay, has it been like more than 2 years? Has it been less than 2 years? And if it is something that's been going on for a very long time, chances are it's not a sick call issue. So you have to kind of ask, like, what made you come in today then, if this has been going on for 2 years? Because you might get a slightly different answer where, yes, it's something that's been an issue for 2 years, but they just flared it up 2 days ago. And then that is a sick call issue. So that's the first part of this is when did this start, and then you can also include what were they doing when it started. Were they doing a 4x36? Were they doing a 12-mile ruck? Were they at rest and it just gradually all of a sudden started hurting? You can get a lot of different answers for that. So P is provocation, basically what provokes it, and that's what makes it worse. What causes those symptoms to happen? Let's say you're having knee pain. Is running what makes it worse? Is it when you're squatting? Does it hurt at rest? So you can kind of include what makes this worse, but also what makes this better. Does ice help? Does heat help? Does resting help? You can include both of those in provocation. Next is quality. So it's how do they describe it? And a lot of people don't really know how to describe pain. So this one can be kind of difficult, and you might have to, again, like bait them into giving you a good answer where you'll say like, okay, is it achy? Is it sharp? Is it stabbing? Like let's say someone has pain in their abdomen and we want to know exactly what's going on. There's a huge difference between cramping type pain versus like a sharp stabbing pain that's happening in the right lower quadrant, right? Like two very, very different planes that we're going to go down. Next, R is radiation. So does this pain stay in one spot or does it move? And the most important one to ask this on is like, let's say someone comes in with chest pain and it's radiating down their arm, right? If someone has knee pain and it radiates down into their ankle, good to know, but it's not going to significantly change my treatment plan. But we always want to ask, is it just in that one spot or does it kind of spread out? Next is severity. This one, fairly straightforward. So this is 0 out of 10. How much does it actually hurt? And you might have to guide people a little bit on this because a lot of people will say, oh, it's a 10 out of 10. And they're comparing the pain that they're experiencing right now to the worst pain that they've ever experienced in their life, likely, is what they're comparing it to. And so you have to explain to them. I tend to use something called the punch in the face scale, which gets a laugh out of people, but it also gets us a pretty accurate answer where you say, okay, so you're saying right now your pain is a 10 out of 10, but you're sitting there pretty comfortably. So let me explain this to you. If I were to punch you in the face right now, that would be about an 8. A 10 is like you're unconscious, like on the way to the ER. If I punch you right now, that's an 8. So like, what's your actual pain scale? And that usually gets us a pretty accurate answer where they're like, oh, okay, it's like a 5 or 6. Like it's enough that I notice it, but it's, I can still walk. It's not debilitating. I can still function. That gives us a more significantly different and more accurate answer. Some people use like a mauled by bears kind of scale, where like 10 is like you're being mauled by a bear. That also gets a pretty accurate answer. But you might have to explain that one to patients a little bit if they're sitting there pretty comfortably and say, yeah, I'm actively in 10 out of 10 pain, because we all know they're not, but they don't understand that. Okay, so you have to give them benefit of the doubt. They might be in a 6 out of 10 pain, sitting there comfortably. We just have to make sure we're getting the most accurate answers. And then the last one is trend. So some people in one version of OPQRST, they have T as time rather than trend. I've always liked to include time in onset and then trend later in T. And so is it getting better since this started? Is it getting worse since this started? And it's important to know, is this something that has like continually gradually gotten worse or better, or is it kind of flaring up and then getting better and then flaring up and then getting better? And we would describe that as intermittent. So an example of ways that we can include all of these things in a very short couple sentences on a SOAP note is, let's say someone comes in with knee pain. I'm going to say 26-year-old female presents with knee pain times 3 days, worse when running, better with rest, describes as achy, no radiation, 3 out of 10, getting worse since onset. Very simple, very straightforward. And this is just one of those other versions of another acronym that you can use. So old CARTS, is one that's familiar to a lot of people. All, similar things that we're looking for here. So onset, location, duration, how long has it been going on, characteristics, I think that's more of the quality. And then alleviating and aggravating factors. So that's your provocation, radiating or relieving factors, and then timing, when did it start, and severity, just like we would in OPQRST. So same information, just a slightly different format. I'm not picky about which one anybody uses as long as you get the right information. All right, so second part of subjective that people tend to forget about is AMPLE. And some people also use the acronym SAMPLE, and that just includes like signs and symptoms, but we're already including that in our SOAP note and in the OPQRST. And so if you use AMPLE, and I'll typically just write this off to the side in my SOAP note, there's a little like column on the left on our 5181s that you can just write AMPLE and put this little bit of information in there. This one's super easy, but we tend to forget about it a lot. And it's super important, especially if we're going to give someone a medication. Really important to know all these things. So first thing I want to know is allergies. Do they have any allergies? Is it to medications, food, or environmental? If someone says seasonal allergies, like I'm chances are not really going to write that on my SOAP note. It's just a matter of like noting that. But something that they have like an anaphylactic reaction to, I want to write that down. If some medication causes like a rash, these are the things that we really need to know. Other things to put in there, if you're familiar with G6PD, that's basically a disorder that causes people to have sensitivities to certain medications. And so I would definitely put that under allergies as well. Next is medications. So what do they actually take on a regular basis? Let's say someone comes in for knee pain that just flared up 2 days ago, but they're already taking Celebrex every day for their back. What I can't do is give them ibuprofen if they're taking Celebrex every single day for their back. And so very, very important to ask people these questions. P is past medical history. If someone's coming in for knee pain, I don't necessarily care that they had a tonsillectomy at 10 years old, right? So use some judgment here. You can filter out what's actually important. If someone's coming in for knee pain and they had an ACL surgery on that same knee, or even the other knee 5 years ago, that's information that I want to know. That's pertinent to what they're coming in for today. So use your judgment here. This is like anything that they're chronically diagnosed with, surgeries that they've had, stuff like that, things they're actively being seen for right now. Those are the things that we want to know. And then L stands for last meal or drink. Last oral intake is another way to put that. And E is events leading up to. And so these two I kind of put a star by. And it's because last oral intake is something that I really care about for someone who's coming in with like a gastrointestinal issue, or they're like a heat casualty, stuff like that, when it's more pertinent. If someone's coming in for knee pain, I don't really care that they had Whataburger for dinner last night. It's not going to change my treatment plan at all. But you have to use your judgment here and know which issues are going to require me to do this. So like someone's coming in with like heartburn, or someone comes in with like nausea, vomiting, diarrhea. The fact that they ate gas station sushi last night, that's actually pertinent information that I would want to know. And then heat casualties, like have they had anything to drink today? Have they had anything to eat? Because oftentimes when we're having these heat casualties, it's because they aren't adequately, because they're dehydrated or malnourished. And then events leading up to, I also put a star by that one. Basically, we're putting that in our SOAP note already. So as long as the information is on your 5181 somewhere, you don't necessarily have to put it in the same spot that you're putting AMPLE. Okay, that's just a formatting thing I don't care too much about. Other note that I wanted to make here is anytime you have a female soldier, it's very, very important that you ask their last menstrual period. Let's say you have a female who's coming in for, I'll use the knee pain example again. She's coming in for knee pain, and you asked the last menstrual period, and it was more than 2 months ago, and she normally has regular cycles, but she hasn't had one in 2 months, and not really sure why. Hasn't thought about it too much, but you're thinking about giving her ibuprofen for knee pain. Well, we can't give that to a potentially pregnant soldier. So very, very important anytime you're taking care of a female soldier, especially if there's any chance we're going to be giving them a medication, always ask when their last menstrual period was. And a little bit of my tangent is if you're a male medic and you're uncomfortable asking that question, get over it. You have to ask females that question. It's super important for their safety and for, your safety of your license as an EMTB or a medic. So get comfortable asking uncomfortable questions. Any female who goes to seek medical care is expecting to be asked that question. It's only weird if you make it weird. All right, tangent over. All right, so next part of our SOAP note is objective. Basically, subjective is what are they telling us? What's their story? And objective is what do we actually see? What can we actually see, hear, feel? What information can we gather by doing a physical exam? And so we're going to get a lot more into how to do physical exams in different training sessions, and you'll learn some of those skills. But really, for anyone who comes into the aid station for any issue, you can get a baseline bit of information on them, and that's your general impression of that soldier. And so your general impression is basically, are they alert and oriented? Are they answering your questions appropriately? Do they know what's going on? Are they in any distress? Let's say someone comes in with like a very, very, very severe migraine and they can barely, keep their eyes open. All they want to do is cover their eyes and lay down, and they want to be in a dark room. You can note that and put that they're ill-appearing, like they look uncomfortable. That gives us more information as far as like, unfortunately we do have soldiers that sometimes exaggerate symptoms and they'll say that they have a 10 out of 10 migraine, but they look very comfortable and they look like someone who could definitely go back to work. So that's where you can kind of justify if someone comes in for an issue and they say that they're in 10 out of 10 pain, you can document, hey, like they were alert and oriented, they were in no acute distress, they appeared comfortable and were scrolling through their phone the entire time they were talking to me. There's no reason to believe that they're in 10 out of 10, 10 out of 10 headache. And then we'll do some focused physical exams based on what that person is coming for. So if your ADTMC algorithm leads you to see provider, that's when I would want you to definitely do some focused physical exams. And so we'll get into the details in other training sessions of how to do those exams. But the basic things you're doing are like inspecting. Is there any obvious deformity? You're palpating. Does it hurt when I press on it? You're testing their range of motion. And then let's say they come in for like trouble breathing or like a lung issue, maybe a cough, listening to their lungs, something along those lines. And then there's special tests. And so for a lot of our MSK issues, there's a ton of different special tests you can learn that just give you more information about what could potentially be going on. All right, vitals. Vital signs are so, so, so important. And this is another thing that it seems simple, but we often tend to forget it. There is a section on your 5181, and we'll show another screenshot of that at the end, where your vitals should go. And I've seen it function in an aid station where like the second somebody comes in, we're just writing down their information and somebody's getting a set of vitals and then passing them off to somebody else. I've seen that work very, very well. Anyway, anyone who comes in for any issue should get a set of vitals. And sometimes it doesn't seem like it. Somebody comes in, they're like, hey, can I just get some Zyrtec? Like, I think my allergies are flaring up. And then you take a set of vitals and they have 101 temperature, right? They have a sinus infection. They don't have the sniffles because of the season. That's really important. You have to assume that everyone who comes in is dumb and doesn't know what's wrong with them. And so you have to give them the full workup. And part of the full workup is getting a set of vitals. Even for an issue, like let's say somebody comes in with knee pain and you're like, vitals aren't really important in this situation. Vitals can still tell you a lot. This is how we catch people who have had high blood pressure for years and years, and then they go to aid stations and they go to clinics and they're not getting their vitals taken for certain issues. And then it turns out they've been living at like 150 over something blood pressure for forever. This is where we can catch those issues. And so even if it doesn't seem important, it's important. Vitals are vital. Always do a set of vitals. It does not take you that long, and it's worth it to best take care of your people. All right. SOAP notes. Next, we are on to, we had subjective is what is the patient telling us, what's their story, and then we had objective, it's what are we actually seeing. Now we're at assessment. What is actually wrong and what could be the reason for that issue? The format that I tend to use is diagnosis and then a differential diagnosis. So if you read any of my notes, I tend to put my diagnosis as something very, very broad. So it's like left knee pain. They're coming in with left knee pain. They're saying their left knee hurts. I know 100% that if I put left knee pain as a diagnosis, I'm correct. I'm not going to be wrong. If I put ACL tear as a diagnosis, there's no way at an aid station level for me to verify that information. So I could be wrong. We don't have an MRI at our aid station. So if I put left knee pain as my diagnosis, I'm never going to be wrong. And then I can put out my list of differentials. And so differentials, that's annotated as DDX. And then I'll write out what do I think is actually causing that knee pain. And so I'll typically start with the things that I think are most likely, and then, list out all of the other potential things that could be going on. And so this is kind of your own flair of like you being able to try and diagnose these issues. This is what I think is often the fun part. I get to take their story, I get to take what I see, and I get to try and figure out and piece together the puzzle. And so, for example, I would have, left knee pain. Somebody comes in with left knee pain. It's been going on for a couple of days. It flared up right after they did a 12-mile ruck. I'm going to put my differential diagnosis as overuse injury. Maybe they have a bursitis. Maybe they sprained a ligament. Maybe they strained something. Maybe they have a tendonitis, a meniscus tear, ligament tear, stress fracture. If I think those things are less likely, I'm going to put them there at the end. If I think it's very possible that they have something like a stress fracture, I'm going to put that higher on my differential, and I'm going to put it first. We're towards the end of our SOAP notes here. We had subjective is what is the patient's story, and then we had objective, what do we actually see? Assessment, what do we think is going on? What do we know is going on? And now we get to plan. So plan is also kind of the fun part. This is where you get to work at the top of your scope. You get to figure out what you can do to actually help this person. And so there's a lot of things that we need to include in our plan. And often like our plans will be very, very short and compact and not as detailed as they really should be. So I'm going to spend a lot of time really going into plan. This is the most important part because somebody can walk away and say that we did anything, and if it's not on paper, we're the one that's wrong, right? If we didn't write it, if we didn't say it, if we didn't write it, we didn't actually give it to them. This is where we get to cover ourselves, but we also get to take care of people, which is the whole reason we're all here, right? Is to want to help soldiers, want to do the best for them that we can and get them, back in the fight. So plan is what are we doing about it? One note that I want to make is if you talk to a PA about this soldier, it's never a bad idea to include that in your note. Okay, so let's say we gave someone omeprazole from the aid station. Per ADTMC, that's not really a medication that you all can give, which they need to update ADTMC about that because it still has you giving a different medication that's no longer in favor. But a lot of my medics, if you've seen my medication class, know that I am perfectly okay with you giving omeprazole to someone who has known heartburn and is having those symptoms, as long as you rule out, worst case scenarios. And so if you discussed a case with me, write that in there. Write case discussed with Captain Marchese. That covers you, and it reminds me, oh yeah, they talked to me about this person and I told them to do this. That way it puts all the liability on me, which technically the liability is always on me because everybody's always working under my license, but it still covers everybody and we know what the plan was for that soldier and we know that it was discussed with me. So that's just a little tangent. If you talk to a provider about it, include that in your note. Next is medications. So if we're giving someone a medication, it's very important that we write everything that we actually told them. And so you need to write the name of the medication. You need to write the dose of the medication. There's a huge difference between giving someone ibuprofen 200 milligrams versus giving them 800 milligrams. Huge difference. and how you actually told them to take it. So, ibuprofen 800 milligrams as needed up to every 8 hours. That way they know exactly how to take it. And not only should that be written in your SOAP note, but in the little pill bag that you give that soldier, it should be written on that as well. No one should ever walk out of an aid station with a pill bag that has nothing written on it. That is sketchy, and I don't like it. You write the medication, you write the dose, you write how often they're supposed to take it, and let's say you tell them to take it with food, write that on there too. Okay? So super, super important to do those things. And we'll get into that a little bit more in like the patient education, but there's a lot of things you need to tell people when you give them medication. Super, super important. Telling them, writing it on the 5181, and writing it on the pill bag. Okay. Next, we can get into profiling in quarters. So profiling in quarters, you're going to write on a 689, so their actual sick call slip that they have. You're going to write the length and the restrictions on that form. And that form, the restrictions, there should be an expiration date, how long the profile goes on, and then very, very clearly written out restrictions. Now, when it comes to writing on the SOAP note, I don't expect you to word for word copy what you wrote on the 6181, okay? Or not the 6181, the 689. You don't have to necessarily write word for word because that's going to be very detailed of like what they can and can't do. What I do want is a general idea of where they put on basically, I've air quotes, a dead man profile, or where they put on more of like an own pace and tolerance profile, and how long. That's what I want written on the SOAP note. That gives me a general idea of the profile that they're on and how strict it is. There's a big difference between like no run, no ruck versus like ruck at own pace and tolerance. And if you didn't give them a profile, write that too, right? Because if a soldier tries to, forge a 689, but we have a 5181 that says I didn't give this person a profile, we can work that. Also quarters. Quarters, if you give anyone quarters, absolutely needs to be written on your 5181 and how long those quarters were. Next, we're going to get into patient education. So this is, I'll say this so many times in all of the training sessions that I do. If you didn't write it down, it didn't happen, you didn't say it. So your patient education is any guidance that you gave that person. If you're giving them ibuprofen, did you tell them to take it with food? Did you tell them not to mix other NSAIDs with it? Did you tell them to drink lots of water? Let's say we gave them a decongestant. Those tend to dry you out. And so did I tell them to drink more water? If they came in with knee pain, did I tell them to put ice on it? It's crazy how quickly people will come to an aid station or a clinic with a week of knee pain and they've never even put ice on it, right? So like if you tell them to put ice on it, just write that on your notes. Super easy, just write rice. And then follow-up. This is another one that tends to be quickly forgotten about, but if you never told them to come back, this is where, once again, you have to assume that everybody's dumb, right? Let's say you send somebody away with a 3-day profile. If you don't say like, hey, if this still hurts in 3 days, come back and see us. What if they, assume that you can do nothing for them and they continue to run on a knee that's actually really banged up and make it worse? So, it's simple, like follow up as needed at the end of profile, follow up as needed if symptoms worsen, follow up as needed if symptoms don't improve by whatever period of time, follow up after seeing H2F. Those are just some of the examples of things you can write, but you have to put some kind of follow up because otherwise, we might lose track of these people and they could end up worse if they think that they don't have the option of coming back to us if these symptoms don't get better. Just have a screenshot of the 5181. There's a lot of boxes here. My little like rule is like if there's a box, there should be something written in it. I hate seeing these and there's just a bunch of empty boxes. Even the ones that don't seem important, that just tends to drive me a little bit crazy and make my eye twitch. So, if there's a box, write something in it. The exceptions to that are, the time that the patient departed their unit. We often don't know that information. So, start with, the time that they get to the aid station, and then when you actually start seeing them, and when they leave, you're going to write that in last. The date, screener and location, so you can just write, which doctor, BAS, or you can write just BAS, or, just as long as we know it's the aid station. Chief complaint, what they're actually coming in for, and duration is how long that's been going on. So, that's your O of OPQRST. Make sure that is in that box because that just gives us a quick snapshot of what's going on. Next is the patient residence. This seems dumb. Why do we care about this? Great question, but it's a box on the form and it takes 5 seconds. So just ask it. Okay, so do they live in the barracks? Do they live off post? Just ask and just write it in there. Vital signs. These should always be filled out. Okay, always filled out. Just do it every time. I don't care what the issue is. Do their vitals. It's important. And then you're going to get to algorithm code. And there's also, so if you look, there's that sentence down there, first time for this issue. So is this the first time they're coming to the aid station for this current complaint? You're either going to mark yes or no. And if the answer is no, you're going to ask them, okay, did we tell you to come back and follow up? Or, are you doing that on your own? And that determines, because technically per ADTMC, if someone comes back for a second time for the same issue, that's automatic C provider. And so we want to know, is this the first time they've been seen for this issue? And did we tell them to come back because we wanted to follow up on this issue, because then we don't necessarily need a C provider? But is it an issue they were seen for, it didn't get better, and now they're back, and now that person needs a C provider. And then you're going to get to your algorithm codes and algorithm summaries. So in one of these boxes, you will need to write the actual code that you're using for algorithm for ADTMC. So, B2 or D3, whatever algorithm code you are actually using. And then in the other box, and this is important that you're actually opening up ADTMC and looking at that code and asking them those questions. If you're just looking up the code, writing in the code, and then putting ADTMC away, that's wrong. You should actually be using ADTMC. And then in the other box, the technical, very much right answer is that you were writing in there any red flags and any positive yeses that helped you flow through that algorithm code. And so there are certain things that aren't red flags, but let's say they had a positive yes to one of your questions that led you to C provider. Technically, you are supposed to write anything that they said yes to in that algorithm code in this box. I am okay with you all asking the red flag questions, and if all red flags are negative, putting no red flags. That's me giving you all a little bit of leeway because I want you to do a really good job on your SOAP notes. Okay, so, there's the technical right way to do that, and then there's what I'm going to accept because I want your SOAP notes to look good. Take that as you will. If you have a code in one of those and no red flags or any of the positive red flags in the other, I will accept that. And it's very, very important that you are actually looking through ADTMC and following that algorithm to make sure that it is leading you to the correct treatment plan. All right, and then the next part is there's a comment section. If you look at all of the things listed there, so it says reasons for referrals, any referral, like self-care protocols, follow-up protocols. This is basically the P in our SOAP notes. This is our plan. So if you write S, O, and A on the back, and you, instead of double writing your P, you just want to put your P, your plan, right here, I am perfectly okay with that. There's no reason to write the same thing twice on your 5181 because we're scanning the entire thing into this person's record. So if you just want to put P from your SOAP note in this box, that is perfectly fine with me. That way you're not writing it on the back and writing it on the front. This is where you're putting any medications you gave, any education you gave this person, anything you told them to do, whether you told them to, do rice, use Army RX3, go to H2F, if you sent them to MOD at the clinic. Those are the things that you're writing in this box. And then bottom left, really that's something that you're going to do the very first time that they show up, is like as soon as they get there. This is step number 1 after writing in the times, is like putting in their information. The most important thing to put in there is their name and their DOD. We can, if we absolutely have to, get the other information from their name and their DOD. However, you should write a lot more than that. It should be their name, it should be their DOD, it should be male or female, it should be their rank, it should be their company, their date of birth, all of these things. That way, let's say if their DOD is wrong, I can still get the information that I need with the rest of the information. And then that box on the right is their final disposition. And so did we tell them to go home and rice and come back and see us if they need to? Then I'm going to check off self-care protocol. Did I send them to LaPointe Health Clinic? I'm going to mark off the third one that says PA. Did I send them to the ER? I'm going to mark off one of the ones that says stat. If we send someone to the ER, we don't really know if they're going to see a physician or a PA. So you can mark either of those if we send someone to the ER. And then like hospital clinic referral, that could be something like H2F. Okay, so if we sent someone to H2F, we can check that box. And then under that, it says aid man signature and code. I'm not super particular about this. As a medic, you can sign there, or you can sign on the back after you complete your SOAP note. I'm not super particular about where you all sign. As long as your signature, printed name and signature are both on there somewhere. So I know if there's an issue with this 5181, I know who to talk to about it. That's the most important thing.